إن شاء الله ده تاني يوم في المؤتمر على التوالي، بس الأول أحب أشكر الأستاذ دكتور هشام عوض، وأشكر الهيئة المنظمة للمؤتمر، وأشكر دكتورة رانيا الفراش، رانيا إبراهيم، دكتورة غادة جاد، دكتورة صفاء، كل اللي قاموا أشرفوا على المؤتمر على دعوتهم ليا للمشاركة في المؤتمر ده. Now, Dr. Craig Smallwood will present a topic entitled Electrical Impedance Tomography.
Thank you very much. I have a brand new technology, I'm told, to introduce to you this morning. It's called electrical impedance tomography. It's a non-invasive imaging modality. What I would like to do this morning is introduce it to you, basically how the measurements are taken. This is going to be the first of a two-part lecture series. The second lecture is going to be the clinical application of it, but this morning we're going to look at basically how to set up the device, how to apply it to a patient, and then also look at some images. So here's where we're going to go. First of all, I do have a couple of conflicts of interest related to this lecture. We have received some research support from Draeger Medical, who is one of the very few companies who have an electrical impedance device. They just loaned us the device. It's not like I'm making a whole lot of money. And McKay also has sponsored some of our research related to EIT. So the outline. So we're going to talk about principles of operation. I'm going to review some radiography with you. We're going to look at some MRI images. There are some similarities to how EIT images are obtained, and talk about electrical impedance tomography, and then discussion. So this is what it's going to look like. This is what we're shooting for. This is an actual image from a patient that I recorded and processed myself. And you can see during breathing, the patient's going to inspire, and the lighter parts, the lighter the image, the more ventilation there is in that portion of the lungs. So this is what a typical EIT image would look like. And you can see it's not as beautiful as we'd hope. If it was a nice, healthy patient, we want to see some very nice equal distribution between right and left, and also ventral and dorsal aspects of the lung. So there is some heterogeneity, and this is why we're interested in looking at these images, because our children do not have an equal distribution of ventilation. And that kind of leads us to why this matters at all. We have a lot of important ventilation goals, and a few of the key ones are to achieve and maintain acceptable gas exchange, obviously PaO2 and PaCO2 in our patients. We want to maintain lung protective ventilation. Principally, we do that by gross metrics of lung inflation, but we maintain with positive end expiratory pressure and small tidal volumes or titrated to the specific disease of our subject. Additionally, we want to minimize adverse effects. Anytime we put positive pressure ventilation on our children, we're going to be doing harm to those lungs. So the goal during ventilation is to reduce the amount of injury that we're applying to that patient and giving our patient the maximum benefit of being able to recover from their disease process. Furthermore, we're going to optimize the treatment to their specific underlying disease, and that is really coming down to, I think, much of what 21st century medicine is going to be about, and that is individualized care. So historically, what we've done is apply all these targets of ventilation. So ARDS-net ventilation is probably one of the most famous. So small tidal volumes, a little bit higher PEEP, and trying to minimize peak airway pressure or applied airway pressure. And that has worked across the population fairly well. But what we're moving into now is individualizing the care for individual subjects. So you have a subject who presents to your NICU or PICU with a specific disease. Well, it's no longer going to be enough to look to a guideline and apply a kind of a cookie cutter guideline. We're going to look at specific metrics, differences in how that patient looks clinically, and apply tailored therapies on the mechanical ventilator as well as medication therapies to optimize care. I think that's where we're going. We're not quite there, but we will get there. And we also want to wean the patient as quickly as possible. So once they're healthy, we don't want to waste any time on the ventilators, because time on the ventilator is bad. Opportunity for ventilator-associated events or pneumonia, and also injury by pressure or ventilation. Sorry about that. Okay, so that's why we care. Oh, and by the way, this is a figure from a really awesome article on lung injury. And what you can see simultaneously is we look at these gross metrics of lung performance. So gas exchange, we can look at overall performance of on an X-ray. But you can see during a CT image, we have simultaneously in one subject, we have alveolar overdistension, we have normal ventilation here, tidal recruitment, so that is dynamic airway opening and collapse during the breath cycle, as well as total alveolar collapse, all in one breath. And what we're really struggling with at the bedside is be able to identify these patients, because all we see is a tidal volume and an overall gas exchange. What we want to be able to do non-invasively and not have to take our patients to MRI is identify these inhomogeneity in lung distribution and target a therapy to ameliorate or to fix that. So do we have enough information right now? Why do we even need EIT or an extra device? So this is typically what we'll see. So we get blood gases. I like this one because it's just a nice little paper printout if you have one of those portable devices, but oftentimes it goes to a central lab. We have chest films and MRI or CT images. We have the physiologic parameters as well as some capnography. And capnography, I think, is an area that is really desirable. I'm going to talk about that tomorrow. But these are the things that we have to go on, as well as whatever the mechanical ventilator is showing us on the screen. So the ideal clinical monitor, in my mind, has these principles. It's going to be non-invasive, it's going to be safe, it's not going to expose your patients to increased risk like a chest X-ray would. We don't want to irradiate our patients unnecessarily. It's going to be portable. If you have a really fast processing time, so we could apply it to our patients and get instant gratification. It's also going to be near real time related to the fast. It's going to be validated so that we can trust it. And the one thing I didn't put on here as well is it would be ideally free. We wouldn't have to pay for it all. Unfortunately, I think that's probably not the reality, but I can always dream. So this, I was actually on the plane ride over here, and I was doing my research on your lovely country, and I was very interested in some history. So I was watching a special on the Resurrection Machine, it was called. So it was all about the pyramids and the pharaohs and all the history of the many great pyramids that are here. And you can see here, this is a picture of these researchers, and the step pyramids at Saqqara are in the background here. And this guy is actually using a device very similar to electrical impedance tomography, and I was shocked when I saw this. So he has this soil resistivity tester. And basically they use this in soil exploration, so for mining and gas. And also this guy was trying to find images of forgotten burial sites and structures beneath the sand. And basically what this device does, you can see these little red spikes. So these are going to be these red spikes that are placed in the ground. You're going to apply electricity to it. And basically the soil properties will tell you be different based on the electrical conductivity. So that's what he's measuring. And this is his little device. Fortunately, our medical device looks a lot much nicer than this thing, but the basic principle is the same. So before we get into EIT, I want to talk about radiography. You guys look at these images every day, are experts, but I just wanted to review the methodology just to make sure that the way that we're getting images with the EIT device isn't that much different from a CT scanner. So this is a little picture of what a CT scanner looks like, right? And so an X-ray passes through tissue and it's attenuated at different intensities, and we look at the radio density. That's what we get. That's what we're actually looking at when we interpret chest films or CT images or anything like that. It's the radio density. And the Hounsfield unit, if you guys work closely with your radiologists or look at the chest X-rays really closely yourself, is the unit of that density. And so what a CT scanner does is you stick your patient inside the cylinder. You probably do this more often than I do, and then it'll take a bunch of X-rays simultaneously, circumferentially around this and just rotate. And then what it does basically is the little scanner puts the X-rays through here. This is like basically a potato, right? And you get a one-dimensional image of what the attenuation of that X-ray is, and then you put that all together, and you get this nice little image. And there's a lot of beautiful mathematical processes by which those things are derived, but that's the general process. So you take a bunch of one-dimensional images, you put all those together, and then you can get a two-dimensional image of the distribution of ventilation if you're imaging the lungs with CT. So now let's get into EIT. So this is the general setup. So the EIT is a band. There are typically 8, 16, or 32 electrode arrays, and it can be either individual electrodes, whereby you would just place these electrodes circumferentially around the chest, or it can be a belt. we use with the Draeger device, it's a rubberized belt that has a bunch of the electrodes embedded into it. And so all you do is strap it around the chest of your subject, make sure there's good contact with all those leads, and you have a reference electrode here, plug those both into the box, calibrate it, press start, and that's pretty much all there is to it. Electrical impedance is not so difficult of a topic, and indeed one that you actually look at every day when you look at your physiologic monitor. So when you guys look at the physiology monitor and you see the tracing of respiratory rate, so you put the ECG leads on there and you see a tracing of the respiratory rate. So when the patient goes in, the little line goes up, and that's electrical impedance. Essentially what happens is when you inject a little bit of a current into the body, you measure how much comes out the other side, and as air inflates in the chest, electricity has a really tough time flowing through air. It can flow through tissue and water much more readily than it can air. So that's basically the impedance. So that's the principle that we're leaning on to get these images. And this is, Z here is the electrical impedance, voltage, and amps. So you apply a current, measure the impedance at a given voltage, and that's essentially the crux of it. The unit in which it's measured is an ohm, and you can see here there's all kinds of different impedance values for different body tissues. So the ones that we're most interested obviously are the lungs, and the lung is a beautiful organ to image with this because there's a huge difference in the impedance. You can see the deflated lung is around 7 ohms, and then the fully inflated is 23. So it's a 3-fold increase in impedance once you take a nice deep breath in. These are the settings that we'll set up on the mechanical ventilator. And again, this is a nice little picture of what it looks like to kind of show you the process and relate it back to the way that the CT scanner works. But you can see we've placed these in the lower 1/3. That's typically the placement that we'll do between the 5th and 6th intercostal space. And then we'll strap that around circumferentially on the chest of our subject. And then you have our electrodes labeled 1, 2, all the way to 16. And essentially what the device does is it'll take a pair of electrodes. So right here we're injecting some electricity, a really tiny amount. You can't notice it. The patient will never feel it. But we inject a tiny amount of electricity into the subject and then measure really quickly all the voltage measurements around the whole chest. So that would be one set of images. And then you rotate this to the next, so then we'll inject at 15 and 14 and then measure all around the chest. And you take thousands of images every single second. And this is a simulation, basically, of what that one current distribution looks like in a subject. So we've injected some current here, and then we measure, and you can see if we measure this electrode here, we're only going to be measuring this portion of the lung, but you can imagine every time we take a new measurement, we'll eventually probe every piece of that lung. All right, so here's the cool part. So we're going to start with this mesh, and this is all in the background. So when we do the workshop this afternoon, you're not going to see this mesh. We're just going to see the end product. But I'm going to show you the various steps to get to our beautiful lung images. So we can have we have this mesh. It's called the finite element model. It just means that you put all these triangles in here, a certain number of them. That's the finite element. And then we collect all those images, and this is actually the raw data. This is what the data looks like. So we have differences in impedance for each one of these blocks. So the one big difference with EIT compared to a CT image or MRI is the resolution. So this is the best resolution. This is the actual true resolution that we're getting. So it's markedly worse compared to MRI or CT, and I think that's one important clinical piece that I'd like you to remember before we go into the workshop this afternoon. But we have these measurements. So you can see as these little triangles get wider, that's the increased impedance. So we can see here that we have a decent amount of lung distribution here, and we'll see the largest increase in here, and these are actual patient measurements. And oh, by the way, we're looking at this image the exact same as an MRI or CT. So this is the left, this is the right. And then the feet of the subject would be out here and the head would be behind the screen. That's to orient you to the way the image looks like. So next, there's a process of co-registration, which is basically just translating those triangles into now squares, and we can kind of pick up a few more blocks. We're increasing the resolution a little bit. And then you run some filtering. And then finally, you do some interpolation, which is just an averaging. So it's the same as averaging like a few numbers. So if you average 2 and 4, you get the average of 3. Well, we're doing that now, except for in 2 dimensions. So this is what the image is going to look like when we look at the device this afternoon. But the key, I think, is that this looks really smooth and really quite beautiful. But it's almost lying to you a little bit. because we looked at that very first image with the triangles. That's the actual raw data. And everything since there was just a number of mechanisms to filter, to co-register, and then average the lung image. Interestingly, electricity does not travel in a straight line. So unlike an X-ray, which is pretty straight, you can't really make those beams bend a whole lot by reflecting them off of bone or tissue. Electricity basically kind of travels like in a football shape. So within the thorax, if we have our band here at this red part, you can see there's going to be a proportion of the electrical impedance tomograph measuring different areas of the body. And that's another important difference. So let's look at some images, how we want to interpret these data. There are principally three solid pillars, essentially, of electrical impedance interpretation. One is a functional image. This is basically like akin to tidal volume monitoring. So we're always going to start at a baseline, and that baseline can move from breath to breath. We just look at peak deflation to peak inflation. That's what a functional image looks like. And then a time base, so we can just say at time X compared to time Y, what's the difference in the lung distribution at these two time points? And then absolute. And this one I think is a much more of a research concept, but it would be closely related to an MRI image, and you're looking at a specific absolute value. So global impedance, these are actually data from my lab. You can see, you can't actually really see it that well, but there's a green line in the background here. That's the impedance, and the blue line is the volume. And so you can see as this patient breathes in, the volume goes up, the impedance increases as well, and then consequently when they decrease, they both go at the same time. So they're very closely related, and there's lots of good data to relate those two things. And at this point, we can be very trustworthy of the electrical impedance as it changes over time. And this is essentially a similar image. So we see the global impedance. Now we're only looking at two big breaths here, but you can see the snapshots, what those images look like at each one of those time points. So at peak deflation, so before the first breath is initiated, we see there's not a whole lot of changes in ventilation here. Patient breathes in, get another image, and you can see it's much wider. There's a lot more increase in impedance, and then we can say ventilation. And that's essentially what it looks like. This we don't care about too much. I think I just want to say that this is a really hot area of research. So it's a relatively new technology. It's not even FDA approved. So in order for us to get images on our patients, we have to get an investigational device exemption through our IRB. But in the literature, you'll see it's just exploding with researchers across the world trying to interpret these data, applying it to patients, trying to derive important clinical information. And this is an example of a bunch of different ones. I'm going to show you a couple of key ones. I think that the most interesting or practical are things like the Global Inhomogeneity Index. So essentially what we want to do is, okay, we don't really care about what the total global impedance is, because that's basically tidal volume. What we care about is breaking that image up into other smaller pieces, because we think that smaller, more finite information is going to be what's special about this device and can tell us something that our mechanical ventilator can't already tell us. So lung volumes. So this is a CT image over here, and we can see that we have a ventral, basically mid-ventral and a dorsal portion of the lung, and then these three alveoli are representative of the end expiratory lung volume during ventilation in that subject. What happens is that in a healthy lung, we have, I'm going to let that play. We have a homogeneous expansion of those alveoli, and that's basically what we'd like to see. So every single piece of that lung, so the most ventral to the most dorsal, is mostly homogeneous. Yeah, it's homogeneous. And so if we have a really sick subject, though, that image would not look like that at all. And right before I may have a time for a few questions, I just want to leave you with this image of some data from our lab. On the left here is obviously a CT image where you can see very, very good distribution of ventilation. There's really no areas of collapse and overall good aeration. And what we see with the simultaneously recorded EIT image is that we've broken it up now. So we're looking at overall, we can see that there's probably very good correlation between this lung expansion and over here. But what we typically do is split the image up into these four quadrants. And so we can look at ventral, mid-ventral, mid-dorsal, and dorsal. And this is generally the percentage distribution of ventilation that we'll see in a healthy subject. So I think that's important for a couple of reasons. One, we want to know what basically a baseline or what a healthy subject looks like, such that when we have a sick image next to this, we know what to compare it to, and we can interpret it a little bit more readily. And number two, I think one of the most interesting areas of the lung is this dorsal region down here. So later today, I'm going to take you through our laboratory experiences, why that's important. But in the meantime, I think I can leave you with the fact that we all have learned about regional distribution of perfusion. Dr. West in the 20th century really was a pioneer, and there were some really foundational, I think, really important pivoting our understanding of pulmonary perfusion in an animal lab. He looked at dogs and said that because hydrostatic pressure increases, these patients are laying down. And so the gravity basically is going to be sucking all the blood down. That's basically just a fact of life, essentially. And so what we find is that in the most dorsal regions of the lung, the perfusion is the greatest. And what that means is that we want to have a proportional increase or equal distribution of ventilation to that region if we want to maintain ventilation-perfusion matching. If we can maintain good perfusion ventilation matching, then we can therefore hypothetically optimize our care, optimize gas exchange, and then get away with even reducing ventilatory settings even a little bit further. So that's the general goal. Obviously here most of the ventilation is in the mid portions of the lung, but I hope to show you this morning and convince you that this is probably areas 3 and 4 are probably the most clinically important at this point, but I'll leave that for now. So thank you very much.
Thank you for this interesting lectures. Any questions? Okay.
Thank you for your nice presentation. I would like to ask if this technology entered in the bedside management of the patient. Are you using it? Are you deciding, for example, to put the patient in the prone position to have better aeration of the dorsal parts? And do you modify, so you can modify your minute-to-minute management and minute-to-minute ventilation according to what you see?
Yep. Yeah, that's an excellent question. I think that exactly what you just used as an example, so prone positioning, is exactly where we would want to use it. So right now, we're doing studies basically to answer these questions. So we're looking at ARDS, we're also just observationally doing it, and very soon, we're going to be looking at prone positioning. But unfortunately for us, because it's not an FDA-approved device as of yet, we basically legally can't use it to make clinical decisions outside of a research context. So the way that we've kind of got around that in the meantime is that we just have, I think right now, 4 separate IRB-approved protocols that allow us to use EIT. So we can't, so when a doctor, we actually do have doctors who page me or call me and say, Craig, I want to use EIT because I'm not sure if this patient's going to respond to proning, or I want to do a PEEP optimization procedure and I wanted to know the regional distribution. I have to say no, unless we enroll them in a trial. I can tell you that our colleagues in Germany right now, where the device is approved, they use it for their bedside management of ARDS to make these decisions. But in the United States, I have to say no for now, at least until the FDA catches up or until the company decides to pull the trigger and invest in getting approval.
Apparently, this is a fascinating technology. If I can look at a patient who's a neonate with diaphragmatic hernia, and looking at his lung on the left side, gradually expanding, this will help me tremendously, and to take the decision when my mediastinums rapidly shift. So it is like of continuous monitoring as pulse oximetry, as a respiratory rate. It's
yeah, that's precisely right. I think that I will say that the one thing that I think needs to be shown in the literature is really long-term use. So our use is really limited to however long the protocol lasts for. So maybe it's 1 one day. So I basically sit at the bedside for probably 12 or 13, 14 hours straight and monitor for that period. Works extremely well, and we have no adverse risks thus far with that experience. And we also image once per day. But in terms of using the device 24 hours a day for 7 to 10 to 14 to like 30 plus days of stay, I haven't seen that data in the literature, but it's just because we haven't done it. But that's really the dream, right? And as long as it's safe and we have no adverse reaction to the electrode belt and or the electrode array, then I see no reason why it wouldn't be able to be applied for long periods of time and answer these important questions that you're pointing out about congenital diaphragmatic hernia or really optimizing care in any newborn infant who we're just not sure exactly what to do with.
And you can detect your percentage of expansion depending on, it is dynamic, the image is dynamic.
Yep.
And you can detect how much can you deduce, for example, your tidal volume by looking at it, or do you have extrapolation from the curves to deduce the tidal volume, the minute ventilation, all of these?
Yeah, so one of the things that we have done in our lab and people have shown in the literature is if you simultaneously record ventilator data and EIT images at the exact same time, what you can do is then take that tidal volume and then divide it across the image. So you take, or even compliance, that's probably one step better. So we'll look at regional compliance. And what we've demonstrated in a couple of publications is that the overall compliance of a subject is probably on the order of like 0.5 mLs per kilo per centimeter of water. That's usually average for a healthy-ish patient on a ventilator. But what we do is take that overall compliance, distribute it across the image, and now we can talk about regional areas of compliant or non-compliant lung. So that's definitely possible. But it requires the extra step of recording both of those data simultaneously and then processing it together.
And you do have interventional manipulation for altering the regional compliance.
Yeah, so we have,
amazing.
I'll show you this afternoon, I'll step through, it was actually the very first, it was when I kind of got my start into research, and it was a very interesting experience. We went to the animal lab, and it was one of the very first intervention studies using EIT. Because in the literature, I think for good reason, people tend to start with observational studies, and that's where EIT was. We said, you know what, we trust it, we've used it observationally in our ICU enough, we're gonna go to the animal lab and design an experiment such that we're gonna trust data that this device is telling us and use it to intervene to guide care. And what we did was basically targeted PEEP and tidal recruitment maneuvers in these animals who we gave ARDS to. And so it's really, I think it's phenomenal data, and I'd be happy to share with you this afternoon, but that's basically exactly where we see the technology going, is a decision support tool, not just a pretty image to look at.
Thank you.
Thank you for this lecture. I actually have a bunch of questions. Firstly, about the measurements. You can divide the lung into different regions, ventral and dorsal. But the belt makes a cross-sectional image in the lung. It doesn't measure apical or basal simultaneously. I think you have to change the belt, or does it give you an idea about the whole lung from up down?
So correct me if I'm wrong, but it sounds like the question you're asking is whether or not you can get cranial caudal
Yes.
Imaging. And so there are, so the device that I have the most experience with is basically a single plane. So you can only simultaneously record one plane of an image. What we can do is image for 1 minute, move the belt up, record it, move the belt up, record it. Some devices, however, have 2 arrays of electrodes. And so they'll do a 3-dimensional representation of the lung inflation because they have more than a single plane. So it is possible. I have the most experience with just mostly the 2D imaging, but I think that mostly answers your question. And the answer is yes, in some contexts. It's more difficult. And you also have to realize that it's also a little bit impractical for continuous monitoring because the amount of electrodes that you would need on the chest to simultaneously get a nice 3D image would be a lot. And in some cases, I think that might be prudent and indicated, but in most children might be a little bit too much because the more you cover up the chest with belts means you have reduced access for other care and stuff like that.
And with multiple electrodes, what about interference? You will have much interference from the electricity from one plane to another.
So interference from other devices or pacers or stuff like that, is that the question?
Yes.
Yeah, so for pacers, the manufacturer tells us it's safe to use with a pacer. We don't trust that, and plus hardly any of our kids have pacing units, so we just use it as an exclusion criteria. The filtering, there's a tremendous amount of filtering that goes on with a device before you see an image clinically on an approved medical device. I will say that from time to time we do see interference, but it's principally a result of inappropriate electrode contact. So it's not, if we have if we have a low resistance in terms of each electrode contact on the skin, then we're very unlikely to have a poor image as a result of interference from other devices. So these patients will have ECG electrodes, which have their own impedance technology built into them. That is totally fine, doesn't interfere at all. We have other medical devices connected, mechanical ventilators, oscillators, stuff like that, and that stuff doesn't interfere. But just to reinforce that I have some trepidation in applying it to somebody with a pacer, but technically you can do it according to the manufacturer.
About the functional residual capacity, this technology can measure the inflation of the lung dynamically. But to my understanding, it doesn't give you an absolute picture of the functional residual capacity in the lung. But what about the change in functional residual capacity if you are monitoring the patient for a long period? Do the change in functional residual capacity reflect in the image or not?
Yeah, so you're asking it basically, we don't have good absolute information about what the EIT device is telling us, but we can go day to day or even hour to hour and look at changes relative to some baseline in the past. And that's principally how the device is utilized, if that's your question. So what we have done serially, so we're doing an observational protocol right now whereby before a patient is intubated, we get an EIT image, they get intubated, every single day we'll get an image through to 24 hours after they've been extubated. And what we are going to do is look at the changes in electrical impedance, distribution of ventilation, inhomogeneity in terms of compliance of the lung, and show that on day 4 there was a marked change in the distribution from baseline, and that perhaps is reflective or associated with some clinical outcome that was yet to manifest itself.
I'm not speaking about the distribution or the homogeneity index. I'm speaking about the functional residual capacity. Can you see the change in functional residual capacity, or just you are expecting from the change in other parameters?
So if you have an image to compare it to?
Yes.
Yeah, so on the Draeger device, and I think on many devices, you can save an image from a previous, and what you can do is compare that image to your current. And so you can not exactly look at an image like this, which is like a dynamic inflation. You can look at one that's even a little bit more fine grain and show you differences whereby there's increases or decreases in impedance. I think that's perhaps what you're asking for. So you would look at this peak inflation, and if we take a snapshot right now, and then next day take another snapshot at peak inflation, we'd be able to look at differences, and you would colorize that typically with orange or blue. That's just the convention in the EIT literature, and I have some data to show you this afternoon, but I think that's what you're asking for, such that when you're a clinician you could come in and see not the actual lung image, but you would say in the upper left there's an orange part that is representative of a decrease in ventilation in that region compared to your baseline image, and so you can do that.
Okay.
Last question, Dr. Rania.
No,
Okay.
thank you. That would be good. Thank you, Craig. No question. Thank you.
Oh, we got one more.
Hi, sorry, Greg. Just on a practical note, feedback from nursing on a premature baby with delicate skin, with all the electrodes around the chest, and the ability to care for the infant, the ability to undertake an echo, etc. Has there been any issues with that, with skin care and nursing?
Yeah, so that's I think that's a really good pragmatic point, and I will tell you that my experience is typically more with term babies, so I have a less concern, and I've just have less experience essentially with really fragile skin, as is the case with premature babies. I think that the solution is probably to use an electrode belt that is not sticky. So there's no need to basically apply a sticky electrode that then when you need to peel it off is going to take some of the skin with it. Our solution has been to use these proprietary belts available from Draeger that have this black electrode that all you need to get good contact is a little bit of electrode gel or even just saline. And we've had really good images from that, and I think as a consequence, it's probably the reason why we haven't seen a whole lot of skin issues. But I think that that remains to be an important piece of safety data that I think hasn't fully expressed itself in the literature, just because not a whole lot of people have used this device for more than like a snapshot. And so when you get a snapshot, you're really less likely, because you're literally connected for like 10 to 15 minutes, and then that isn't enough time to really develop these skin issues. So I think that there probably will be some skin issues that will need to be overcome, but we just haven't seen that because the small monitoring window. Thank you very much.
Thank you.